Dr. John Bennett, televising from Miami, Florida. Tonight we have the pleasure of having Jordan Schlain, MD, from San Francisco, of the company Health Loop, the healthloop.com, a website or a platform that he's going to explain how it works exactly, but essentially makes communication between doctors and patients better, and it leverages technology to do so, just like I'm leveraging technology to talk to Jordan. Good evening, Jordan.
Good afternoon, good evening. Good to see you.
Nice to see you. So, Jordan, what I like to do with most docs I have these hangouts with, which is, by the way, a lead-in to the conference, the Watch Society conference on Friday. What I like to ask the docs is basically, when did you first know that you had the computer bug, which you obviously have?
Well, I knew I had that in 1980 when the very first Apple II computer was sold. I told my father I wanted one, and I wanted to go to programming school. So I went to a summer camp to learn how to program, and I think it was in BASIC is what it was called at the time. And I started building video games and started learning how to code. And you know, when I was in medical school in Georgetown in 1990, you know, a decade later, I was in the computer lab all the time. There was no internet yet. And then, you know, having grown up, then I did my residency and, you know, started my career in the late 90s in San Francisco. You know, the internet was turned on for real, and Yahoo. One of my residency classmates, her husband was like an executive at Yahoo, and no one ever heard of Yahoo, but she showed us what it was, and I was like, wow, this thing's kind of cool. So I've always been kind of interested in it, and now I'm kind of in the center of it. And it wasn't until early 2000s that I was frustrated that as a doctor, the technology that was going around, whether it was MySpace or Yahoo or like, none of this stuff helped me. I mean, outside of email helped me, and the cell phone helped me. But outside of that, I mean, all these applications that were being designed for businesses were not being designed for doctors. And it actually, fast forward to 2014 today, only now are people taking it seriously that, you know, applications and platforms can be meaningful for doctors and patients. So I've had the bug a long time.
Yeah, it must have been hard to stay in med school having such a love of computers. How'd you manage to do that?
I had a father who was a surgeon.
Oh. He didn't cut you any slack, huh?
Zero slack.
So medicine first, computer second.
That's right.
Well, that's good. That's good. Well, that's good that you can incorporate it into medicine. It's good. You know, it's the same with orthopedists. As you know, the orthopedists, a lot of them that I knew were good with the hands to begin with, and then they went to medical school and figured, wow, there's a way I can use my talent for being able to work with materials. Orthopedists I knew, I'm sure you knew some too, that they were mechanics and did other stuff. And maybe, I don't know if they had any questions when I went to med school, but when I went through orthopedics, I guess they figured, wow, I got mine. But when you went through school, I guess they really accepted. I mean, internet wasn't part of it. Like now, if you went through med school, probably would be a different story. But back then, matter of fact, there's a fellowship in medical devices I just found out. There's a doc out.
Wow.
Yeah, a doc in Houston, Albert Huang, is doing a fellowship in medical devices. It's brand new. But at any rate, when you went through school, that wasn't offered. But now, there's all kinds of stuff. So okay.
Yeah. And I think it's important. Yeah, and I think it's important that we start training our medical students and our residents on, you know, how to think different and think out of the box. I mean, I tell people that, you know, when you're a pre-med and in med school and a residency, you're in the box. And when you come out the other end of the tunnel, you don't even know that you're in a box. Your life is a box. And it's hard to think outside of the box when you're in the box. And with all the kind of culture of, you know, you're subject to the senior doctor, you know, you don't get a lot of chance to think differently or think out loud and be heard, because you've got to toe the party line, and, you know, it's that whole culture of you know, just
seniority. Seniority.
Seniority, that's right.
Yeah. Yeah, that's definitely deeply embedded in medicine. Um,
That's right.
and so what was the evolution? Okay, so you went through residency and where'd you, and when did you first start thinking about something about Health Loop? That type of
So
idea.
it really happened in 2007. I had a patient that had pneumonia, and I gave her antibiotics, and I gave her my cell phone number, and I said, look, you're 70 years old, bad things can happen, but oftentimes, people get better just fine on antibiotics alone, but, one never knows. So I said, here's my cell phone number. If you're not feeling better in a couple of days, please call me. And then 7 days later, the phone rang, and it was the emergency room saying she had been admitted to the ICU for respiratory distress and was put on a ventilator. And I really thought, well, why didn't she call me? I gave her my cell phone number. I made it extraordinarily easy for her to get me. And then my realization was, well, shame on me. Why didn't I call her, and why didn't I check in on her? But the truth is that doesn't scale for doctors. We can't be calling all of our patients.
Yeah.
So after that moment, I decided rather than think about patients in terms of CPT codes and ICD-9 codes, I decided to think about them in terms of how concerned was I that something bad could happen, and how sick were they that they might not be able to interpret that something bad was happening if it was, because they're sick. And when you're sick, you're not thinking clearly, and we can't expect people who are sick to make rational decisions the way we can when we're not sick, because we may have a fever, we may be nauseous, you're just not thinking clearly. So I decided at that moment to call people and ask them if they were the same, better, or worse. Simple question on a daily basis. And then, and people loved the fact that I was communicating with them and calling them, because doctors don't typically call patients on a regular basis. And then I was challenged by one of my patients who was a software guy that said, why don't you turn this into software and make this asynchronous rather than synchronous? Rather than calling somebody, send them an email. So I built a system, very cheap. It was like a prototype. It was more of an experiment in my office, where patients would get an email from me saying, Dr. Shlaim wants to check in. And then in the email, there was 3 links, one that said same, one that said better, one that said worse. And they could click on the link. I got my information. They could delete the email. And I had a dashboard that showed me the trend lines, how everybody felt. And if somebody didn't click any of the links or check in, that was my cue that I should call them, because maybe they were too sick to even check their email. Yeah. And that was the fundamental basis for this. And so, subsequent to that, I presented this at the Kaiser Family Foundation in Washington, D.C. developing a white paper on how technology can help healthcare. And by the way, I was digging through my computer the other day looking for some old photos, and I found a document in 2008 that said it was the architectural framework for Health Loop. And I was like, wow, that's like 6 years ago. And it's funny because I was doing this stuff when nobody was looking at it, and nobody thought digital health was sexy. Nobody knew what it was. And now everybody thinks, oh wow, that's such a good idea. I'm like, I've been like stewing on this thing for almost a decade. Yeah. And I guess the world caught up to me.
Well, I hypothesize that you can contribute as much to medicine if you improve communication than if you invent an antibiotic. It's a simple matter of communication. It's nothing secretive about it.
That's right.
Improve communication. Period.
Well, but the bottom line is that humans are analog. Technology is digital, and so as an analog human, our operating system is analog, and what we want, and the thing that stimulates our operating system is validation and communication, especially around context and a narrative. So Health Loop basically continues the conversation you had with the patient after they've left your office, while they're at home, and it guides them through common things that one can expect throughout their journey. I mean, I typically tell people, look, once you've got your diagnosis and then you've got your treatment plan, that's act 1, scene 1 of your healthcare movie. That's the beginning. That's not the end. Right. But a lot of people are so freaked out because they don't know the diagnosis that when they get the diagnosis, they're relieved. And then when you give them the treatment plan, finally I got the diagnosis and the treatment. But the treatment is a journey. It's never like, one pill and you're done. It's not, and so even if you have surgery, There's the post-op period that can last for weeks and months. And that's a conversation that that patient wants to have with you on a regular basis, because they have questions all the time and you've got answers all the time. And how do you codify all that into a narrative conversation that's steeped in empathy and context, so that when the patient gets a check-in from Dr. Bennett post-op day 10, post-op day 10, you're kind of less concerned about blood clots, you're less concerned about wound infections, you're more concerned about, are they back to their functioning life, are they able to eat, is the constipation gone, are they off their medications? Well, as a physician that on day 10, all these types of things should be clearing up. And you also know that on day 10, patients have all sorts of other questions about when they can get off their crutch, when they can take their cast off. So if you could create that movie, if you will, or create that narrative where it says to the patient, hey, it's Dr. Bennett, it's post-op day 10. You're probably thinking of these things today. Let me tell you how to think about it, and let me ask you how you're doing. So it's a give and a get. And then it takes the get. Like if I asked you 5 multiple choice questions, it takes the get and it distills them into, should Dr. Bennett be concerned? And so then you may get an alert saying, hey, this patient who's post-op day 10 is complaining of cramps in their calf, and you're thinking, well, that could be a DVT. But the patient's thinking they have a calf, and that may be normal because they broke their leg and they have a calf cramp. Patients aren't thinking DVT; they're thinking I got a cramp, big deal. But that could easily turn into a PE and then death. But so how do you frame this in patient language using your medical expertise and just play it forward? So Health Loop is really the ability to codify your knowledge. I call it experience-based medicine, which is in addition to evidence-based medicine. And then you got to bake into the model the preferences. So what are the patient's preferences? Do they want to try to get back to work as soon as possible, or do they want to take as long as it takes to get back? And so once you bake patients' preferences in, you can kind of spell out how aggressive or slow the movie goes, so to speak. But in the end, the patient wants the best outcome, and you, the doctor, want the best outcome. So the way you get the best outcome, to your point earlier, is communication. Frequent, relevant, meaningful, empathetic, contextual communication. And that's what Health Loop does. And so now physicians get these dashboards. And by the way, it's funny that you mentioned orthopedics, because our first use case was in orthopedics. So we've got all these orthopedic surgeons. So we've built a library of content that's wide and it's deep in terms of all the orthopedic procedures. We have hip replacements, knee replacements, broken legs, ACLs, sprained ankles, podiatry, hand surgery, spine surgery, anything in orthopedics, because A, it's expensive, and B, it's debilitating. And so when you take expensive and debilitating, well, the healthcare system wants to decrease the expense. The patients want to get better as soon as possible. So our first use case is in orthopedics. Now we're going out into gynecologic surgery, urology, cancer. Anybody that wants to build the content, we have the platform to build it. So does that make sense?
Yes. Well, I just have a specific question. Okay, when a patient comes to your office in the Health Loop system, what kind of discharge instructions? Are they given links? Are they given a sheet of things to watch for, a contact number?
No, even better. We give them a prescription. We take our prescription pad out, okay, and we write a prescription to them, and the prescription says, check your email.
Okay. Okay, so you send them an email?
So they get an email that says, your doctor would like to check in with you regularly. Click here to activate this. And it's like an app. And then basically they validate that they are who they say they are with a birth date and whatever validation techniques that however strong the doctor wants to be. It's all HIPAA compliant. And once they do that, then on a regular basis, the discharge instructions are all embedded in this narrative over time. Because the truth is, if you give someone a one-page discharge instruction, that one page has 15 things in it, 15 elements in it. But the truth is some of those elements you don't want that patient needs to know on day 6, not on day 1, not when you gave it to them. And when you discharge somebody, they're not feeling well, they're on narcotics, they had surgery. The last thing you want to do is give them complex instructions at that moment. So what we do is say, look, you don't need to know anything except for to check your email, and then post-op day 1 and says, hey, look, don't forget, your handicap placard is right here. Download it, and send it to DMV. You know, your narcotic usage should be going away in 3 days. Don't overtake narcotics. You may get constipated if you take narcotics, so don't forget to take the Colace. And then it says, did you, you know, so there's all these things that in the loop where there's instructions, there's videos, there's confirm that you did this, there's how are you doing, there's things to track and monitor. So a loop contains multiple elements, and you, the doctor, can build, you know, it's like a Lego set. What do you want and where and how much do you care about it?
Right. So yeah, so it's a program that leads to certain links if you click here and etc.
Yeah, yeah. I mean, it's what we found in orthopedics, for example, is, you know, when you know, if you ask a surgeon who's the best doctor they know, who's the best surgeon they know, you know what the answer is?
Yeah, me.
Me. Well, so and I grew up with that stuff. So my father was the best surgeon he knew, and you know. And the truth is that, you know, someone's better than somebody else, and not everyone's the best. It's impossible. So what we've done is we've interviewed hundreds of orthopedic surgeons, and what you find is there's a common narrative or a common thread of things that they care about, complications they want to avoid, things they want education of patients about. So we now have this scaffold whereby 80% of the content, every orthopedic surgeon will agree on those things. It's the 20% that's variable that we let them adjust and modify and make it in their own language. And, you know, depending on if they're old or they're young, they can start to kind of modify. You know, it's not like a template where you just say it's an order set, here's the one I'm using. Because John Bennett may say, look, this is the way I do it, and I want to make sure they, you know, they do sit-ups on day 2 and they drink tea on day 4. Of a very and then what you can do is you can compare John Bennett and, you know, and John Smith down the street, and you can start to measure outcomes. Because the one question we ask patients is, hey, were you able to walk today? Were you able to go back to work today? So you get these functional outcomes. Were you able to have a bowel movement today? So what the patient cares about is, when do I get back to normal life? What the doctor cares about is, I don't want a complication like a blood clot or an infection. So what the doctor cares about and what the patient cares about are typically different things, but so the outcomes that we measure are both surgical complications, whether it's a wound infection or a DVT, or even a fall or a mechanical or like a failure of the device. But we also measure from the patient standpoint what they care about. Like, I want to get back to work as soon as possible, right? So if that's one of their preferences, then we're going to check and see. So if all your patients are back to work 15 days after a hip arthroplasty, and your colleague, everyone's back to work 22 days after hip arthroplasty, well, let's drill into that. Maybe you're doing something better than your colleague, and now we have a best practice engine where we can say, look, you said do sit-ups, and for some reason doing those sit-ups is enabling people to get core strength, and they're able to walk sooner. So that's something we should distribute to everybody because we've learned something from you. So it really democratizes research without having to do massive clinical trials.
Okay, so you're establishing a little big data set.
Yes, little data is the new big data.
Little bit. Well, you know, well, that's great. You're essentially networking with your own patients.
Yes.
You're building a network with your patients, which is excellent. Because I'm sure that some patients feel intrusive, and because I've seen patients, and you have too. Oh, I didn't want to bother you with this, or I didn't think it was important, and that kind of takes it out of the equation.
But when you make the communications asynchronous and they're not bothering you. So one of the things that we found, John, which is fascinating, is, and it was something that, you know, it's a kind of orthogonal, and nobody really thought that it was going to do anything, but we have a doctor that signed up for Health Loop, and he's been putting an orthopedic surgeon. He has gotten 6 5-star ratings on Yelp and Health Grades in 1 month. Wow. And his ratings have gone from like a 3.8 to a 4.5 because the patients feel like they're being heard and they have a venue to communicate.
Right.
Whereby in heretofore they had to make a phone call or an office visit, and they felt like they were intruding, and now they don't. So it's really quite, so now we're kind of like focusing on, look, do you want to be a 5-star doctor? Here's how you do it. Use Health Loop. It's simple as that. And categorically, every doctor that's using this, their ratings are going up because people are saying, my doctor communicates with me, knows exactly where I am in my process, is communicating the right things, and I can like say something to them.
Yeah.
And it's usually your nurse that may be the first responder for what they're saying, because your nurse has pattern recognition and knows that when they say, "Hey, is this normal?" Your nurse can, on behalf of you, it's transparent. We're not hiding the ball. Yeah, yes, that's normal. Don't worry about it. And if it gets worse, I'll let Dr. Bennett know.
Well,
Right, and so
yeah.
it's kind of, it creates an operating system for a medical practice in a way.
Yeah. Well, one question, Jordan. Each doctor individualizes his own health loop follow-up instructions, according to what, like the total hip, say. Each doctor that does total hips will individualize what he thinks.
Kind of. I mean, here's what we'll do is we'll say. So we went to the chairman of a large academic medical center, and he said, "I'm the best doctor I know. I'm the chairman of orthopedics." And so he said, "Look, no one does it the way I do it." And we said, "Well, let us show you what we think you'll do." And he looked at all this stuff, and he said, "You know what? 80% of what you've said, I would agree with, but the 20% of the stuff, I want to tweak a little bit."
Right.
So he tweaked the 20%, but it's like go online and tweak it, and easy to do, and before you know it, it's live, and then we can start learning as to whether his 20% is getting better results than the other guy. So we're really kind of results oriented.
Do you notice a pattern of acceptance among different specialties? Like certain specialties embrace this readily, and others kind of resistant, or?
I would say that every specialty has their early adopters, those that fancy themselves as innovators, and
right.
then look. When the winds of change come, you can build a wall or you can be a windmill, right? And so every specialty has the windmills, and they are embracing this. And their patients, at first they're like, this isn't going to work, but when they see the patient satisfaction scores go through the roof, they're like, you know what? And it's no extra work for the doctor. You actually do more for less, and you do better. So it's more and better for less time. So kind of our value proposition, would you like to save time and silence your phones? Because every phone call that comes into your office, on average, is 7 minutes when it's all said and done. Because it's a call, maybe it's a callback, it's put on hold, everything needs to be documented. So one phone call is 7 minutes. We've studied this. And we can do, I think it's 12 health loop interactions in 7 minutes. So you can have 12 communications with one patient, or you can have one communication every 7 minutes with one patient. And so it's highly efficient to have your staff communicate with all these people. And by the way, oftentimes you're just told, hey, look, you're tracking 22 people right now, and 21 of them are doing just fine, and only one of them requires your attention. So you don't even really need to do stuff, because it does it for you, and it surfaces the exception. So it's really exception-based medicine in context that makes the patient feel heard. And in fact, we just got a deal with an insurance company, MedMal insurance company. They are going to lower MedMal by 10% for doctors that use HealthLoop. Because the number one reason why lawsuits happen is patients feel they weren't heard. It wasn't that you cut off the wrong knee or operated on the wrong side. Those are sensational TV stuff.
Right.
But it's really that the patients are upset that they weren't heard and nobody talked to them. And the other thing, especially in orthopedics, is that patients say, hey, the doctor never told me not to walk up a flight of stairs on day 6, and I did, and I re-injured the hardware in my foot. But with HealthLoop, we put that, you got that email on day 3 that said don't walk until day 10. And so everything that's supposed to be documented is documented, and it's validated that you checked in and you saw it. So you can't say, doctor never told me. We auto-document all those things. So, again, I am an accidental software guy, because this was an experiment in my office.
Yeah.
It seemed like a good idea, and what we're finding is there's Easter eggs all over the place that we did not foresee. I would have never thought that I was going to lower malpractice premiums with this. Mm-hmm. And there's all these things we're finding on a daily basis that I would have never guessed. So it's more of an epiphenomenon.
One of the things I'm sure that you sell your program in is the importance of reputation management amongst physicians now with the internet, because patients can easily get on the net and say stuff, and I think a doctor that doesn't recognize that nowadays has its head in the sand.
Well, that's right.
The internet is very important as far as your reputation.
Well, we walked into a large orthopedic practice the other day, a few months ago, and they said, look, we don't need this stuff. And we said, how? They said, they said, we're the best orthopedic practice in this neighborhood. And so we went to, we printed up in advance, and we showed them their reviews, and they were like 3.2 out of 5 stars across all the things. And we showed the other practices. We showed this practice all the other reviews that the other patients were sending, and immediately they're like, wait a minute, if we do this, our ratings will go up. And they signed up, and their reviews, all their ratings have gone up consistently every month by, like, 3.8 to 3.9 to 4 stars. So it is truly resonating with physicians that reputation management really matters. And that's almost like a marketing line as opposed to a clinical outcomes line. Because if we charge them and say, look, buy this software because it's a clinical outcomes tool, they say no. Or it's harder to sell, but when you say it's a reputation management tool, they say, oh yeah, let's spend the money on this, because these large orthopedic groups will buy billboards and they buy radio ads, and they spend a lot of money on marketing. It's like, your best marketing is your reviews.
Yeah, I imagine. Yeah, you must have a good team of marketers and programmers.
Yeah, no, I mean, the company's grown pretty fast, and it's just a fascinating journey, because I'm like the accidental entrepreneur, really. Is
this platform limited to the United States, or do you find that it's going on to other countries?
No. We have governments of other countries looking at this right now, and we're agnostic. We don't care about language or country.
Okay. Yeah.
And one of the large cancer centers that have people come in from all around the world that go to the cancer center, then they fly back to wherever they came from. This is a great way to stay in touch, and keep that conversation going when this person who just had cancer is at home. So
actually, it could apply to industry too, or or for business. Have you ever thought of doing that? Kind of like applying it to business? Not you personally.
John, there is so much wood to chop. There's so little time.
No, I know.
By the way, I am a full-time doctor. I was seeing patients all day today. So I mean, my day job is there's a team of people doing Health Loop, and I wish I could do mitosis and divide into 2, but I can't.
Yeah, of course. But one thing that I've how about the conference about Google Glass? How much experience have you had with that? Because you have.
I know a lot about it. A lot of the companies out here. So as a result of my exploration in digital health, a lot of companies now come to me and say, hey, what do you think? And I get your advice, because I'm still practicing. I have real practical understanding of what I call the problem surface of the healthcare system, which is doctors and patients trying to solve problems in the context of a highly regulated, dysfunctional system. Okay. Sorry, I gotta.
Okay.
Speaking of which, there goes an ambulance.
Go ahead. Do you use Google Glass in your practice now?
I don't right now. I'm waiting for it not to look the way it does.
Okay. They have designers working on that now.
Right. Exactly. As soon as it's not that, I'm all in. I feel like right now when I see somebody with Google Glass, I'm not sure if they're looking at me or they're looking at their glass. And so that's kind of disturbing to people, especially around here, because there's like a huge pro Google Glass movement, and then there's a kind of a anti Google Glass movement. And I think once it's not obvious, then that's okay. Oh, okay.
Yeah, things will change. It's a very dynamic field, and it's very deeply entrenched. And you know what? It surprised me, Jordan. It's gone into a lot of specialties. It's not just surgery. Interventional cardiology, there's a neurosurgeon that we were talking to. Of course, it appeals to most surgeons because of the freehand type thing and the video aspect of it. And one thing I just, from talking to Albert Huang, the gentleman that's doing the medical device fellowship in Houston at Methodist Hospital, he's an MD. He's one of these MDs that's very talented. He has a degree in industrial design, and he's going to be one of the guys that may change the design of your Google Glass that you may like, because he works on design of Google Glass. But he said something. He was talking about how he uses glass to teach. And they have a concept called tele-illustration, where suppose you were doing surgery now, and I was watching, I could actually get on the screen and pointing to where Jordan's exploring this wound and the different anatomical structures with my pen. I could be pointing towards it.
I think that's fantastic.
I'd never heard of that.
I
never knew it existed.
It's great.
Yeah, there's lots going on. Okay, Jordan, I won't keep you too long from your family eating oysters and on Fillmore Street in San Francisco. Enjoy your meal. I would love to have you on some night to go through your program, the whole.
I would love to show it to you. I would love to show it to you, and you know, it's something you may want to use or try. I mean,
I think it's a great thing. It sounds like a great thing, and it's something that medicine needs: better communication between doctors and patients.
That's right. Remember, and I'll leave you with two thoughts: is that the way medicine is kind of operated today is no news is good news. Your patient leaves your office, if you don't hear from them, no news is good news. But the truth is no news is no news, right? Yeah. Good news is good news. So that's one thing that I think we need to remember, that, you know, and it's historically we don't want it's too hard to get the news, so we'd rather not get it. The other thing is with all this wearables and with all this collection of all this data, people think that more information is better, and my point is more is just more. Better is better. More is not better. So we have to make sure that we get more and better, not just more. Right. And so there needs to be some filtration mechanisms to take this more and make it into better. Yeah. And I think a lot of people are a little bit deluded into thinking that if we collect all this stuff, it's going to make it better. But doctors want to do less with more, not more with less. Yeah. Sorry, there's a huge thing going on. So anyway, on that note, I'm going to go join the family. But John, I will see you and talk to you soon. And thank you for the time to chat.
Jordan, it was a pleasure meeting you. Thanks for your contributions.
You bet.
Good night.
All right, good night.